So yeah, hello everyone. This lecture is going to be a quick overview of some of the common pathology of the foot and ankle. Um, some of the common pathology that I see and treat in my practice, and then all the X-rays that I put in the slides are from actual patients that I treated. And I'll save some time so I can answer questions at the end. So this lecture is going to cover anatomy. We'll talk about some foot facts, talk about some biomechanical issues and malalignment. We'll talk about some common conditions, and then non-operative and operative treatment. All right, so the foot and ankle has 28 bones, 30 if you include the two sesamoid bones that everyone has along the first metatarsal phalangeal joint. There's 33 joints, 112 ligaments, 13 extrinsic and 21 intrinsic muscle. And what that means is that there's intrinsic just means that the muscle is within the foot. Extrinsic means that the muscle starts in the leg and it comes all the way down and inserts in the foot. There's 4 leg compartments and 9 foot compartments. All right, some interesting facts. There's about 250,000 sweat glands in a pair of feet, and they excrete as much as half a pint of moisture each day. 2.5-inch heel can increase the load on the forefoot by 75%. The average person takes 8,000 to 10,000 steps a day, which adds up to 115,000 miles in a lifetime, meaning that you can walk around the earth 4 times in your lifetime. 75% of Americans will experience foot problems at one time or another in their life. 60 to 70% of diabetics will develop some form of diabetic nerve damage, which is in severe form can lead to amputations. 56,000 people per year lose their foot or leg due to diabetes. And then approximately 60% of all foot and ankle injuries, age 17 or older, are ankle strains or sprains. All right, so there's 5 podiatric emergencies that are urgent and need urgent treatment. That includes gas gangrene, necrotizing fasciitis, which are both infections caused by bacteria that are limb-threatening, open fracture, compartment syndrome, which is a condition where regarding an injury or bleeding, the pressure builds up and kind of causes necrosis of muscle and tissue. And so urgently have to release that compartment. And then neurovascular compromise, where patients are not getting circulation or secondary to either an open fracture or peripheral vascular disease or diabetes. All right, so systemic diseases that manifest in the lower extremities. So there are many systemic diseases that manifest early on in the lower extremity, which allow us to detect and diagnose them before they progress or become debilitating. And so some of these conditions are diabetes, neuropathy, peripheral vascular disease, rheumatoid arthritis, Raynaud's, DVT, melanoma, and gout. So for diabetics, oftentimes it presents in the skin, a condition called diabetic dermopathy, where there are like dark lesions that are present all over their legs. With diabetes, also we can notice autonomic nervous system dysfunction, which means that the sweat glands fail to work and patients develop severe dryness. Also with diabetes, you can develop neuropathy, which means abnormal nerve function, leading to lack of sensation, and sometimes numbness, tingling, burning, and even pain. And so oftentimes we're able to diagnose this in the office. We can use a Sims-Weinstein monofilament test, which is a small wire that we're able to measure the pressure. Also, another test is a sharp and dull, where we're able to see if the patient can determine the difference. And then a deep tendon reflex or a tuning fork, where a patient will to test their vibration. Also, we're able to see the circulation in the feet. Sometimes patients have varicose veins or diminished pulses, lack of pedal hair, shiny skin, diminished capillary refill time, skin changes. So these are all tell us how the circulation, if it's adequate or not in the foot. With rheumatoid arthritis, we're able to see fibular deviations, which means the toes kind of drift to the outside of their foot. And sometimes we're able to notice some rheumatoid nodules. So oftentimes, if we see this and the patient is not diagnosed with rheumatoid arthritis, we're able to diagnose them. Okay, so oftentimes you can develop skin lesions throughout your lifetime. So these could be corn or calluses. Corns are typically on top of the toes. Calluses are usually on the bottom. And so in diabetics, these lesions are considered pre-ulcerative because it's an area of high pressure, and eventually, if it's not taken care of, the skin will break down and patients will ulcerate. These lesions could be warts, which are virus. Warts are basically skin lesions that develop from a virus, the human papillomavirus. Porokeratosis, which is a clogged sweat gland. And both of those lesions can be very painful and cause discomfort. Other lesions, which are a little rare but can present, include melanomas, basal cell carcinoma, squamous cell carcinoma. Ulcerations are also common in diabetics or people who have neuropathy. Those are some of the lesions. So corns and calluses are really secondary to a biomechanical problem. So oftentimes, if you have the corn over here, it could be related to our callus over here. It could be related to arthritis in the big toe joint. If you have callus on the bottom here, it could be secondary to elongated or plantar flexed metatarsal. Oftentimes, if it's on the side, it could be related to a Taylor's bunion or a bunion. If it's on top, it could be related to a hammer toe, which is a curling deformity. And so this is kind of like a seated corn, which is another term is porokeratosis, which is a clogged sweat gland. Also, they could be in between the toes, and it could be secondary to a bone spur that's irritating the area. So this diagram is very nice in demonstrating how foot instability leads to skeletal instability. So this is a diagram of somebody who's overpronating. And so somebody who's overpronating is somebody who has flat feet. And so this is optimal pressure where everything's aligned, perfectly midline. You could see on the scan, pressure is on the heel and on the ball of the foot. Somebody who has flat feet with a scan, all the pressure is red, and you could see that there's really no arch. All the weight-bearing surface is all through the red spot. And so that's somebody who's overpronated. They put a lot of pressure on the inside of their foot, inside of their knee. And so if you kind of look at this diagram, it affects, pronation affects the ankle, the foot, the knee, the back, the neck, the lower back. And so a way that we can kind of improve the alignment and stability or the foundation is we can do that with orthotics. So with orthotics, we're able to, realign the foot so that way all the pressure is even in the knee, the hip, the back, and throughout the lower extremity. So, ideally, this is what you really want, which is a neutral foot. This is the right foot, and so this is the inside of the arch, and this is the outside. And so typically this is the range that you want to be. Somebody who's overpronating on this side is somebody who's got flat feet. They put a lot of pressure on the inside of their ankle and the bottom of the heel. And somebody in this range, somebody who's oversupinating or somebody with a high arch who is also not good. They put a lot of pressure on the outside of their ankle, and they can get tendinitis. And, both conditions can lead to problems proximally in the knee, hip, and back. And so this diagram is pretty good because it shows how orthotics improve that function. So if you look, this is actually somebody's left foot, but basically they're pronating, right? You can see the medial ankle bulge, you can see too many toes on this side. The heel is in this position, and so the tibia is down here. So they don't really intersect. With orthotics, we're able to get the heel underneath the tibia and in a better alignment. And so this not only will help the foot, but help, with any knee pain, hip pain, back pain, because everything's aligned properly. Okay, so other conditions that we see, this right over here is something called a paronychia, which is an infection secondary to an ingrown toenail. This is nail fungus. You can see nail discoloration and thickening. This right here, although it looks very severe, it's actually benign. And so this is subungual hematoma. So this is secondary to trauma, whether it's from your shoe gear, often seen in runners or anybody who dropped anything on their toe. And so that discoloration will disappear over time as the nail grows. Okay. Some forefoot deformities include bunions, hammer toes, which is curling the toe right over here and puts uneven pressure. You can have a tailor's bunion or a bunionette, which is a bunion on the fifth metatarsal phalangeal joint. Other forefoot deformities. This is the rheumatoid arthritis patient with fibular deviations. You see how the toes kind of go out laterally. This is somebody, it's going to be a congenital deformity called metatarsus adductus, where patients are born with this condition, and it can make it very difficult to find proper fitting shoes. Rearfoot deformities include, pes planus deformity, which is flat feet, and that could be congenital or it could be acquired. Oftentimes, the acquired patient is secondary to posterior tibial tendon rupture. So the tendon that comes along here that supports the foot, and it can kind of tear or rupture. And when it does that, the arch kind of flattens out and collapses. Often it's seen in PEDS patient where they can also have a similar condition, but they have often an accessory navicular, so an extra piece of bone that's in this area. And oftentimes we treat that with orthotics, and orthotics fail. We end up doing surgery where we remove the accessory bone and we attach the tendon up here so that way it can kind of form an arch for them. On the bottom here, this is somebody with a very high arch. This is a Charcot tooth, which is a congenital condition as well that causes plantar flexed metatarsals as well as a high arch and hammer toes. And this is a clubfoot. So this is a congenital deformity where a lot of patients are born with it, and it's important that they seek treatment right away, which would involve casting, serial casting, and oftentimes it's tenotomy, which means we release the Achilles tendon to help get the foot underneath the leg. Okay, so now we're going to talk about some of the common conditions and treatments. And so this right here is a bunion. The clinical term is hallux abductor valgus deformity. So a bunion is actually a triplane deformity. It's not an overgrowth as some people might think, which can cause a dislocation at the big toe joint, which can lead to pain, swelling, imbalance, abnormal gait, and difficulty wearing shoes. Oftentimes it's hereditary, but a tight, non-supportive shoe can accelerate the progression of the deformity. 1 out of 4 adults have bunions, and it's typically progressive, meaning that it gets larger over time if it's not treated. The bunions can lead to arthritis or other forefoot pathologies such as hammer toes, capsulitis, plantar plate tear, and neuroma if left untreated. So this is what a healthy foot looks like. You can see the joint is aligned properly, and this is what a bunion looks like, where the metatarsal shifting out of alignment, causing the big toe to drift inward. This affects the joint, and it causes the appearance of a large bump or growth. So some of the treatment options include shoe gear modification with a wider toe box to avoid pressure on the bunion. Orthotics can also help delay progression of the deformity. Bunion shield, which is this image right over here, can decrease pressure from shoe gear and make it a little bit more comfortable. Toe spacers is what this is, and it kind of prevents the big toe from rubbing up on the second toe and decrease the pressure or corns. You could also get a splint, which is what this is. This typically only works for about 1 to 2% of bunions, because a lot of times bunions are a bony deformity, not a soft tissue deformity. And so it's kind of initially you can kind of splint with this, but it typically does not provide much treatment. Other options are anti-inflammatories or cortisone injection to decrease the inflammation. And so these are really just all short-term conditions. They don't actually treat the problem, which is the dislocation at the big toe joint. So really, if we wanted to address this, the treatment would be surgery. And so there's about like 25 to 30 different bunion procedures that can be done, but the most common ones are the ones that I have over here. So this is considered an Austin bunionectomy, where we shave the bone and we do a V-type osteotomy, and we're able to move the capital fragment to realign the joint. And so typically we put 1 or 2 screws in this area, and patients do well. Here's another one. It's called an Aiken osteotomy, where we're taking a little piece of wedge from the bone, and when we rotate it to close it, we're able to correct the deformity. And usually we can use a screw or a staple in this area. And so these two are usually done for mild bunionectomy. You can combine both of them for a moderate bunionectomy. And then for a large bunion, you need to do this type of procedure, which is called a lapidus, where you do a fusion back here at the origin of the deformity, and we're able to get a powerful correction. And so I'm going to show you an example of a patient who came into my office, and she had a bunion deformity. So this is her left foot, this is her right foot. You can see that the joints aligned properly. The 2 sesamoids bones are right underneath the metatarsal where they should be. If you look over here, you can see that the sesamoids are not aligned. And you can see the bunion deformity joint is not aligned properly. So typically the first ray is elevated. You have valgus rotation of the sesamoids, and there's a transverse deformity over here where the intrametatarsal is large. And so this can cause, arthritis if left untreated, and deformity and pain, affects balance. And so, we decided to do the lapiplasty or fusion at the tarsal-metatarsal joint. And so this is 6 weeks post-operative treatment where we did the fusion. And so we did it using 2 blades, and you can see that the sesamoids are in line and the joint is properly aligned. And so here's the lateral view. So you can see that this patient also had a flat foot, and you can see that the middle of the foot is collapsed because of the flat feet. And so typically that's also one component of why you have bunions, is because having flat feet kind of loosens the ligaments and the bones kind of typically drift. But following the procedure, you could see that, the joints are actually lined properly and the patient now has an arch. So this is a very powerful procedure that collects both the bunion as well as flat feet. Another condition is called hallux rigidus. So this is arthritis of the big toe joint. So typically it's bone on bone, which causes limitation of motion. You can have pain, swelling, stiffness, and it could be genetic or it could be secondary to trauma, post-traumatic. So a lot of athletes get this, because especially basketball players, where they get stepped on often, or somebody who sprains their big toe joint. Over time, it leads to inflammation and arthritis. And so here you can see that there's the joint space is narrow. This is a normal, healthy joint. You can see that there's a lot of space between the 2 bones. Here, there's really mild space here and here. So this is the example of bone on bone. There's subchondral sclerosis from the impact of the bone on each other. If you look over here, you can see that there are large bone spur formation, which limit mobility. And so some of the treatment options include conservative treatments. So shoe gear modification is important. You can get something like a rocker bottom shoe, which allows you to roll off the big toe joint instead of bending it. That will take pressure and decrease some of the pain. Another treatment is orthotics, where we add a Morton extension, which is a fiber, which is basically a rigid extension that limits motion, because every time you have motion, it causes pain and inflammation. So by eliminating the motion, patient will symptoms will improve. We could also do anti-inflammatory cortisone injection, but this doesn't prevent the arthritis. It just makes patients very comfortable. And really, to treat the arthritis, patient would need surgery. So in terms of surgery, there's different treatments. First one we'll talk about is a chelectomy, which is really this procedure is done for a patient who has the start of arthritis. So somebody who's got stage 1, stage 2 of arthritis, where basically they just have bone spurs. Really, they still have a joint, they're able to move, but the motion might be limited from these two bones rubbing on each other. So the procedure basically involves removing the bone spurs and cleaning out the joint, and that'll give the patient more range of motion. You can have a joint replacement. So this is a total joint replacement where we basically remove the arthritis and we put a prosthetic joint. And so this is a scholastic implant that allows patient to function very well and have motion back at the toe joint. So they're able to walk properly. They're able to wear heels if they wanted to, and they're able to do yoga and certain things that they didn't do before. Here's another joint replacement, but this one's a hemi implant. So we use the hemi implant instead of a total implant. So typically, we decide this procedure based on how bad the arthritis is. And the last thing is a joint fusion. So typically we remove the cartilage and we're able to align the joint in a better alignment and basically fuse it. So this is typically somebody who's like, say somebody's 30 or 40 years old who has, 60, 70 years to go, and they want, one procedure that will last a long time. And so doing this fusion would allow patients to continue running and being active, and basically it can withstand a lot of pressure from running and impact. And typically once it heals, it's a one and done procedure. So the next condition we're going to talk about is gout. So gout is an inflammatory arthritis that occurs when too much uric acid, they form crystals and they deposit in the joint. And so this can occur in any joint, but the first metatarsal phalangeal joint is the most common, which is the toe joint. And it's so common that it actually has a name. It's called podiatric. The hallmark include redness, swelling, and hot joint. It's most common in men, but more common in women who are postmenopausal. And the reason why you get this is due to eating too much high protein, increased alcohol intake, dehydration, or being on diuretics. So typically this condition it used to be called King's disease, and because a lot of kings used to drink a lot of red wine and eat a lot of red meat. Some of the treatments include anti-inflammatory, colchicine and methicillin are the most common used. We could do a cortisone injection, or you could take prednisone. And another treatment is allopurinol. So this is typically for patients who have gout for chronic, where they get like 2 to 3 flare-ups per year. We're able to put patients on this medication, and that can prevent gouty attacks from happening. Right. So most oftentimes patients are able to improve with anti-inflammatory or cortisone injection, and as long as they monitor their diet. Okay, next condition is a Morton's neuroma. So this is not an actual tumor. It's basically scar tissue that develops around the nerve secondary to pressure or inflammation. Some of the symptoms include pain along the ball of the foot. You can have numbness, burning, tingling, which radiates to the toes. Patients often report that they feel like they're walking on a pebble, or their socks are bunched up. Most common area is between the 3rd and 4th toes, followed by the 2nd and 3rd toes. And some of the treatments include a shoe gear modification with a wider toe box, orthotics with metatarsal pads to decrease pressure off the nerves, NSAIDs, cortisone injection, alcohol injections, and when these don't work, we can do surgery to remove the nerve. And so this nerve is really just sensory. It doesn't, it's not important. It doesn't control any muscle or anything. So by us removing it, we're able to get rid of the pain. The only thing is that after removing, we might have a little bit of numbness between those two toes. Another condition is called capsulitis, or pre-dislocation syndrome. This is basically inflammation of the capsule ligaments surrounding the metatarsal phalangeal joint, and the most common one is the 2nd metatarsal phalangeal joint. This is usually caused by elongated 2nd metatarsal, which drives a lot of pressure along this area. Having a bunion or tight calf muscle or flat foot can also lead to this condition. Treatment includes anti-inflammatory, cortisone injection, orthotics with a floating pad along the second metatarsal flange. If this condition is left untreated, it can result in a plantar plate tear, which means you develop a tear on the bottom here, and this can cause drifting of the second toe. So the second toe can start to overlap the big toe, or it can overlap the third toe. And typically, surgery would be required to repair the plantar plate, to repair it and get rid of the tear, so that way the toe can sit down in proper alignment. Another condition that's often seen is a stress fracture, also called a marsh fracture or a hairline fracture. And so these are tiny breaks in the bone secondary to repetitive stress, such as running or jumping. It's common in runners, athletes, also common in a patient who has osteoporosis or osteopenia, or somebody who's on chronic steroids. Typically, patients will have pain and swelling along the top of the foot. X-rays, sometimes it might not show up initially on X-ray. So if you injure your foot and you go get an X-ray the same day, it might not show up. Sometimes there's a latency period where it could take 10 to 21 days for it to show up on X-rays. And so if that's the case and the patient has a high suspicious, we might have to order an MRI, which can diagnose the stress fracture. The treatments often include protective immobilization with a cam walker boot or a hard cast. Typically, patients do very well with just a boot. And so if you look on this diagram, this is the break right here in the third metatarsal. And then as it heals, patients develop a bone callus around the fracture. And so this is a good sign that the bone is healing. All right, another common condition is plantar fasciitis. This is the most common reason for heel and arch pain. It's inflammation and sometimes tiny tears that occur in the plantar fascia. Heel or arch pain with first step in the morning and with ambulation or after prolonged rest are usually what patients complain of. The tenderness is usually along the medial calcaneal tubercle, which is the inner aspect of the heel. And so treatment options include low dye strapping, which is a taping technique to support the arch, orthotics, anti-inflammatory and cortisone injection, stretching and physical therapy. And if all these conditions, treatment options don't work, there's a surgery that we can do, which is called an endoscopic plantar fasciotomy, where we release the medial 1/3 of the band and release that tightness, and patients do very well following the procedure. But most often patients do well with orthotics and injections. Okay, Achilles tendinitis. So this is an overuse injury causing inflammation along the Achilles tendon. It can often be associated with a retrocalcaneal bone spur or Haglund's deformity. So if you kind of look at this diagram right here, this is a patient that actually has both a Haglund's deformity and a retrocalcaneal spur. So this is the retrocalcaneal spur. You can see there's a lot of swelling around the area, and basically the Achilles tendon attaches. And so the spurring can cause degeneration, inflammation, and patients typically have pain right along this area. A Haglund's deformity, which is an enlargement of the back of the heel right here. You can see that this is where the heel should end, and this is all bony growth. And so typically patients who have this condition have pain along the retrocalcaneal area, and they develop retrocalcaneal bursitis. And so oftentimes a lot of pain can develop in this area, and we can give a cortisone injection in this area. Typically, we avoid any cortisone injection in this area because it can kind of affect or damage the tendon. But we try to target it in this bursa, and that usually helps patients' conditions. Here's another patient that has an isolated retrocalcaneal spur where the Achilles attaches. So you can see all the swelling. Here, they don't have the Haglund's deformity. You see how this is perfectly straight, whereas in this one, kind of edged out a little bit. So the treatments include heel lifts to take pressure off the Achilles tendon and the bone spur, anti-inflammatory or cortisone injection if it's a retrocalcaneal bursitis, stretching or physical therapy. And if that doesn't work, then surgery is the next option. And so for surgery, there's different techniques that we could use. There's something called a 10x procedure, which is a minimally invasive procedure where we're able to put a probe right in here, and we're able to get rid of, it targets only the disease or inflammatory tissue. Also, there's another probe that we can use that can kind of debride the bone. And so what's good about this technique is that patients obviously often don't have any stitches, and they just wear a surgical shoe for a couple of weeks, and there's relatively no downtime. But there's always limitation with minimally invasive procedures because, if the bone spur is this large, we might not be able to, debride all of that with one small incision. And so the treatment would be a posterior spur excision with Achilles tendon repair. And often this is what the surgery would look like, where we would remove the spur and the Haglund's deformity and repair the Achilles tendon. Okay, now we're going to shift towards diabetes. So uncontrolled diabetes can lead to neuropathy, which is lack of sensation, as we discussed. It can lead to peripheral arterial disease, which means that patients develop poor circulation, as well as small vessel disease. So peripheral arterial disease basically means that the circulation in the larger vessels are narrow and are not working properly due to occlusion. Small vessel disease means that the little tiny circulation in the toes and digits are affected. And typically this is seen a lot in diabetes. And it's very difficult to treat because the larger vessels, vasculature is going to open up to increase flow. But with the small vessels, there's really not much options that can be done. We hope that by opening up the large vessels, that can kind of increase pressure and open up the small vessels, but oftentimes it may not. So uncontrolled diabetes can lead to delayed healing, ulcerations, Charcot Arthropathy, which we're going to talk about in a second, infections, complications, and amputations. So Charcot Arthropathy, this is basically a condition secondary to diabetes. Usually a patient who has uncontrolled diabetes or hemoglobin A1C, higher than 9 can develop this. And basically what it is just breakdown of the foot. So the foot breaks down, patients will have redness, hot, swelling, and it can almost look like an infection. And oftentimes patients will go to urgent care and they'll be placed on antibiotics, and they might not improve. Really, you need to get x-rays to see if the foot is breaking down. And really, we treat this by offloading. So the clinical condition is called Charcot Neuropathic Osteoarthropathy. It's a serious and potential limb-threatening lower extremity complication of diabetes. It's an inflammatory syndrome characterized by various degrees of bone and joint destruction, secondary to neuropathy, trauma, and altered bone metabolism. The hallmark deformities midfoot collapse or rocker bottom foot, which is right here, as opposed to a normal foot where you have a high an arch. So typically it starts with trauma, with neuropathy, then inflammation, then osteolysis, which means basically fragmentation of the bone, and then fractures and dislocation. And so the treatment, like I said, is offloading. Typically you want to offload the patient for at least 3 months to allow them to heal. We could do that with a total contact cast, a cam walker boot. A crow boot is a specific type of walker for Charcot. And then we can do custom orthotics. So typically we would offload the patient with the boot for 3 months, kind of take serial x-rays to make sure that the bone fragments are healing properly and the fractures are healing. And then after they're healed, we put them in orthotics so that way they don't break down furthermore. There's also medications that they can take to kind of help strengthen the bones. And then there's surgery that we can use. So oftentimes in patients, their joint breaks down, they can lead to a bony prominence, which can lead to a wound that can get infected, and it can lead to osteomyelitis, which is a bone infection. So oftentimes, if that's the case, we just shave down the infected bone or the bony prominence, and patients will do well. Sometimes we have to do a skin flap over the wound to allow it to heal. Also, we could do a reconstruction, which is, kind of a complex surgery where we do uh, beaming, which is basically put like large bolts in their foot to stabilize it. You could also use an external fixator, which is device that goes on the outside that basically offloads the patient and helps with deformity correction. And then sometimes, treatment is an amputation to help the patient um, get rid of any infection and deformity and allow them to be ambulatory again. And that's my presentation. Thanks for having me. Any questions?
Oh, thank you so much. That was great. So comprehensive and interesting. So somebody was asking about, they had a bunionectomy, think of that, 30 years ago. And now the right big toe seems to be like sort of loose and wants to go over the toe next to it. No pain, but very uncomfortable. And is there a suggestion for that? Does that happen sometimes after bunionectomy?
Yeah, so typically, bunionectomy has bunions have a high chance of recurrence where they can come back. And so looks like your bunion is probably coming back and it's causing the big toe to drift over. And so, you know, probably the best thing to do is get an x-ray and see exactly, you know, what's happening and if the joint is aligned properly. Oftentimes, if it was over 30 years old, the surgery used to be where, the podiatrist used to just shave the bone. Nowadays, we kind of try to correct the deformity where we're able to put screws or do a fusion to help the alignment and prevent recurrence. So, you probably need an X-ray. I mean, you could use, a toe spacer, but it's not going to prevent it. You're always going to have to use that. And, if you're looking for a long-term solution, then, you might need a revisional surgery to straighten out the joint.
Okay. I think the surgery is probably a little bit different than it was 30 years ago, I would think, in every way to a degree.
Yeah, I would agree.
Absolutely. Somebody was also got a lot of sort of people want to exercise here. And how would you determine, maybe what sneaker is best for like a walking shoe or someone who's fairly active, who's a senior? Is there anything you suggest?
Yeah, so typically the best brands that we recommend, I mean, a running shoe is usually very good. So some of the brands, sorry, excuse me, include Asics, New Balance, Saucony, and Brooks. So they're a well-made shoe. They have a wider toe box. They have a lot of cushioning, and so you know they can prevent against injuries. And if you have a bunion or a hammer toe, it'll be more comfortable in those shoes.
Okay. Um, Somebody was asking about just managing calluses and even slight discomfort from Taylor's bunions. Is there anything that you suggest or?
Yeah, so I mean, if you're having a callus and the Taylor's bunion is basically a biomechanical issue, and so we can certainly shave down the callus, and it's just going to come back, whether it be like 3 months or 6 months, or if you wear a tight pair of shoe, and so you know we can continue doing that, and you can use pads like a bunion shield. But if you're looking for a solution, if you have surgery, then the callus goes away, and the toe will be straight.
Mhm. Also, do you provide, like, could someone make an appointment with you just to go over orthotics or order orthotics, doctor?
Yeah, we do that all the time. So basically, you would come in, we would take a look at your foot type. If you need X-rays, we'll get X-rays. Then we have a laser scan where we scan your feet for orthotics, and we make it geared to your condition or pathology, or based on your alignment.
Okay. it- Someone is asking, is there an age requirement to a bunionectomy? Like at one point, do you not do it,
Yeah, so typically there's really no age. I mean, if you're having pain and discomfort and it's affecting your ability to walk, exercise, or do things you like, then that's when we'll do the surgery. Obviously, the sooner you get it done, the better, because you can, if you're having discomfort, or your quality of life isn't as good because if you have a lot constant pain or you can't exercise because of pain, then it's good to do it. But I mean, I've done surgery on patients who are 84, 88, and so who are pretty active, and so it's all based on your lifestyle.
Right, it's all relative. Let's see. And somebody was asking, they were just curious, is plantar fasciitis genetic at all? Is it hereditary, or do you know why?
So typically plantar fasciitis is not genetic, but having flat feet is genetic. So the flat feet could be a reason for your plantar fasciitis. Also, equinus, which is a tight Achilles tendon, is genetic, and that could be a common reason to develop, plantar fasciitis. So there's a lot of different reasons to develop plantar fasciitis from a biomechanical standpoint, but plantar fasciitis is very common. Everybody gets it. A lot of people get it, I should say. And so if you're working on your feet, doing heavy lifting, or it can easily get inflamed. So athletes get it, doctors get it, nurses get it, police officers get it.
Yeah, very common, so common. And do you have any suggestions for somebody who's maybe a bit younger? Like how would you what would you suggest to keep your feet healthy and safe to avoid problems later in life? Is there any tips that you have?
Yeah, so I mean, as long as you're doing usual foot hygiene, make sure you're washing your feet. Everything's really geared to if a patient's having an issue, but in general, just make sure your health is in order. You know, if you have diabetes, you just have to take more care of your feet, making sure the diabetes doesn't, get worse and lead to, neuropathy or, you know,
Hmm.
ulcerations or anything like that. I mean, for somebody who's young, I mean, it's just, make sure you're not wearing tight shoes to prevent any bunions or hammer toes. Make sure that you aerate your toes so you don't get any athlete's foot or nail fungus.
Hmm.
Stuff.
And just somebody had a question about hammer toe surgery. Is it effective? Something you do a lot, and just she had concerns because a friend's toes were damaged. I don't know exactly what that means, but I guess just a comment on hammer toe surgery.
Yeah, so I do hammer toe surgery often, and so there's different types of procedures that we can do where we just remove a little piece of bone to help straighten the toe. Sometimes if there's arthritis there, we might have to put a pin in there to keep it straight, or an implant. So they're relatively effective. Not really sure what was done with your friend or what kind of procedure she had. Um, but there's different conditions. Sometimes it might not just be a hammer toe. You might have that plantar plate tear where the toe is drifting. So there could be a combination of things that are happening. Maybe that could be a reason why it wasn't affected if it wasn't addressed. But typically patients do very well and the recovery is pretty short. They can get back into sneakers at like 2 to 3 weeks.
Hmm. Okay. And what is there any reason or anything you do about feet that always feel sweaty or damp? Is there any condition with that?
Yeah, so I mean, if there's a condition called hyperhidrosis, so if your feet are constantly sweating, also sometimes if your armpits are always sweating, that could be just a genetic condition. And so there's
Mhm.
different powders that we can recommend. There's also something called a dry sol, which is like a deodorant that you basically would rub on the bottom of your feet that blocks the sweat glands. And typically you would prescribe it and you would apply it at nighttime when the sweat glands are very active. And you put it on once a week or so, and that can kind of help with the sweating. Also, if you have athlete's foot, that could be a reason why. I mean, if there's any malodor or odor, that could be due to athlete's foot. So we kind of evaluate that during the exam as well to make sure that's not contributing.
Mhm. And one more question. What is the treatment for oversupination?
Yeah, so there's different treatments for oversupination. We can certainly make you orthotics to help put your foot in a more neutral position, so you're not putting all the weight on the outside of your foot. That can help. Obviously there's surgery that we can do, or we can kind of, do an osteotomy and put the heel underneath the tibia, so that way it's better aligned. Typically, orthotics kind of do the trick.
Okay. Well, I'm seeing some thank yous. Very good. Thank you so much, Dr. Hanna. We really appreciate you taking the time to educate